I'm Dr. Colleen Loo-Gross. I'm a family medicine physician and faculty at the University of Kansas School of Medicine, Wichita. I serve as the Director of Clinician Engagement and Education with Alce Su Voz.
And I'm Glenn Martinez. I am a professor of Spanish, bilingual bicultural studies, and public health at the University of Texas at San Antonio, and currently I serve as president of the National Association of Medical Spanish.
So we're here today to talk about the care of patients from linguistically diverse backgrounds, also referred to as those with limited English proficiency. Let's start by putting this in context. So in the United States, our population is becoming increasingly more diverse. According to the U.S. Census Bureau, between the years of 1980 to 2019, the proportion of people who spoke a language other than English in their home increased from about 1 in 10 people to 1 in 5. So as clinicians, we might ask ourselves, why is this important and why is this relevant in healthcare? It's because promoting equitable access to health language services, as well as culturally appropriate services, are important in improving disparate health outcomes and overall health equity in our communities.
Exactly. And Colleen, I'd just like to add that I think that there's a legal framework that's also connected to this. Language access is very much rooted in civil rights legislation. So, tied to Title VI of the Civil Rights Act, we had an executive order that was signed in 2000, Executive Order 13166, that basically said that in order to comply with civil rights legislation, it was required that all agencies that received federal funding needed to provide language access to their populations. And that really triggered a lot of activity in various different areas, but particularly in healthcare. And the Office of Minority Health in Health and Human Services put out in 2001 the national standards for culturally and linguistically appropriate services, or what we call the class standards. So those were issued as sort of a blueprint for health and healthcare organizations to implement and provide culturally and linguistically appropriate services. And the standards were really intended to advance health equity, to improve quality, and to eliminate health disparities. From 2001 to where we are today, there's been quite a bit of uptake of these class standards. So the class standards were, they were kind of introduced as accreditation standards by the Joint Commission, and that was put into effect in 2010. In 2013, the standards were revised and released again as the sort of enhanced class standards. And then in 2016, Section 1557 was added to the Affordable Care Act. And all of that legislation requires that people who have a non-English language preference be provided the language access that they need to be able to access quality health care. And just recently in 2023, a language access plan was put out by the Department of Health and Human Services, again, emphasizing this need to provide language access to language minority patients, communities, and their families.
I think it's important for us to remember that we can't just define a person by the language that they speak or their preferred language. And for that matter, we can't define someone by any single or individual characteristic. Language is a method of communication. But sometimes in clinical scenarios, we may inadvertently attribute or define a person as the language that they prefer to communicate in, or perhaps even a specific medical condition. But often we don't realize that we're doing this. We are much more complex as individuals, and that relates to our health as well. So this really doesn't do us justice. This is a good reminder of how important it is for clinicians to really focus on patient-centered care and really engaging the whole person in our encounters, both in the visit as well as throughout the lifespan. With that in mind, how is it that we deal respectfully with communication differences in the clinical setting? There are a number of challenges associated with not only the linguistic component, but also the cultural component of this.
Yeah, and Colleen, I think that that's just so right. That sometimes, you're working with an interpreter and you're following all of the protocols, but you're still not getting the message across, right? And I think we need to take the broader perspective and really think about acceptance, welcoming, the importance of connecting, looking directly at the patient, building that relationship, understanding language as a marker and a tool for racialization and minoritization. I mean, these are all, I think, big issues that come into play when we talk about language access. It's not just a simple problem with a simple solution. It's a very complex reality with a complex response, equally complex response.
An important concept that we're going to talk more about today is implicit bias, and specifically in this context. We all have implicit bias, and I know that many people may have a certain kind of gut reaction when they hear that term, but I can't emphasize this enough. It does not make us bad people. I've heard implicit bias described as an invisible fog that kind of surrounds us in society, and we just start breathing it in at a very young age. And we just don't realize that it's happening. And by definition, it is unconscious. It is unintentional. In the clinical setting, even the best, most well-intentioned clinicians may inadvertently approach a patient in a different manner because of the preferred language, or perhaps because they identify with a background different than the clinician. And this is just one of the ways that language, along with the assumptions assumptions that are made around a person's preferred language, may perpetuate inequities and lead to poorer health outcomes in our communities. Fortunately, though, we can learn to interrupt and overcome these biased thought processes. And the first step is really to talk more about it, have these conversations, and increase our own awareness.
Yeah, just along those lines, Colleen, I like to kind of share a story from my own experience. I remember when my wife was pregnant with our second child, our daughter, in Tucson. She developed gestational diabetes during her pregnancy. We were living in Tucson, Arizona at the time, and she was seeing a very well-intentioned, well-meaning physician, was really great. But when the gestational diabetes diagnosis was encountered, the doctor, told my wife in all seriousness, she said, I have something I'm going to tell you, and I want to make sure that you understand this. So she brings in an interpreter, and here's the interpreter here just to make sure that you understand it. And, that was something that my wife had never interacted with the physician in any language other than English. And even though she speaks English with an accent, she felt really offended that that the doctor would bring in an interpreter. The doctor, in a well-meaning way, but the doctor brings in an interpreter, and she felt like she was being singled out for her accent. And I think the real nugget that came out of this for me, the real sort of truth that came out of this, is that oftentimes as clinicians, as practitioners, we want to take care of the language. We want to treat the language, and we have to remember that we're not treating the language. We're treating the person, right? We're treating the patient, right? And keeping that in mind, I think that we can often unintentionally, create these harms through biases that we have based on a number of different types of social cues that we receive.
Mm-hmm. Absolutely. And a large component of this is really about the clinician-patient relationship, again, coming back to that idea of person-centered care and how we effectively do that, particularly for our patients who are linguistically diverse and from historically marginalized backgrounds.
Exactly.
In order to achieve this person-centered care, however, we have to first ensure that we are able to communicate fully with all our patients, regardless of their preferred language and in their language of choice. We are excited to have Rommy Vargas MA joining us in this conversation. Rommy, would you like to tell us a bit more about your background and your connection to this work?
Okay, hello Colleen, thanks for having me. I'm a CCHI certified interpreter in the healthcare field, and I hold a master's degree in Spanish and education. I am from Peru, and I have worked in the translation and interpretation field for more than 20 years. I also do health, community, and education interpretation. Currently, I am the Director of Interpreter Engagement and Education at ALCE Subos, providing the 40-hour medical interpreter training for interpreters and individuals that are interested in entering this field, and also interested in taking the examination to get their certification. We also provide at ALCE Subos different workshops related to different topics that are of interest for the interpreters.
Thank you, Rommy. You mentioned experience in both interpretation and translation, and I think it's worth taking a moment just to distinguish the two because I think the two terms are often confused. So as a reminder, as we know, interpretation has to do with oral and spoken word, whereas translation has to do with written word.
That is correct.
And today we're shifting into talking about interpretation in the medical setting. However, before we continue that conversation, I just wanted to briefly acknowledge the ever important role of bilingual clinicians in the healthcare setting. There's a lot more discussion to be had around that and what it means to self-assess or to formally assess a clinician's language skills. Mm-hmm. However, for the purposes of our conversation, we will continue by talking about interpreters in the medical setting and how we approach that in terms of best practices. So first, whenever possible, we want to make sure we are using a trained and qualified medical interpreter.
Well, thanks for that, Colleen. And I think that it's worthwhile to underscore that trained and qualified portion when we talk about medical interpreters. What do we mean by a trained and qualified medical interpreter? You know, interpreting, I think, has been going on as long as humans have existed. But it wasn't really until sort of after the Second World War where interpreting really began becoming a professional field. So in the Nuremberg trials, right after World War II, we see the development of the first instances of simultaneous interpreting, which really gave way to the creation of professional interpreters who were then, deployed in the United Nations as sort of professional, what we call conference interpreters. That later gave rise to a series of sort of professional developments in the area of interpreting, including the 1978 Court Interpreters Act, which requires that federal proceedings in federal court have an interpreter present, and that interpreter must be a trained individual, trained and assessed not only in their language skills, but also trained in principles of interpreting. So, this idea of a trained, qualified medical interpreter really talks about how an interpreter is a professional who has a certain code of ethics, who has certain standards of practice that we can reliably expect them to adhere to in their practice. So, thinking about the importance of professional interpreters, I think we need to recognize that while it is enough to be bilingual, being bilingual is one part of being an interpreter, but it's really not enough to be an interpreter. Just because you're bilingual doesn't mean that you are an interpreter, right? So there's a difference between bilingual skills and interpreting skills, and the professional interpreter brings in those additional interpreter skills. We know that there are many benefits of using professional interpreters, which include fewer communication errors, improved patient satisfaction, service as a cultural liaison, and they're associated with typically shorter hospital stays and reduced readmissions rates. Those are some of the benefits of professional interpreters. Many clinicians and folks who are kind of listening to us talk will recognize that there are different modes of interpreting and there are different modalities of interpreting. So when we talk about modes of interpreting, we're talking about the simultaneous mode, which is two people speaking roughly at the same time, delivering the message in one and another language. When we talk about consecutive, which is a second mode, we're talking about a person delivering a message, that person pausing, the interpreter providing the message in the alternate language. So that's consecutive. And then finally, there's sight translation, where a person will take a sheet of paper written in one language and sort of paraphrase or deliver the content of that text in a different language. So those are the modes. And then we have modalities, right? So a modality refers to how that interpreting takes place. Is the interpreter physically present in the room with the clinician and the patient? Is the interpreter on a telephone and away somehow remote from the clinical encounter, or is the interpreter on a video link connection where the interpreter has the visual cues of what's going on in the room, but they're not physically present. So those are three sort of modalities of interpreting, and these are a variety of options that are available. Typically, the in-person option, the in-person modality, is the preferred option, even after COVID, where everything kind of went remote. But I think coming back, we still consider the in-person option as the preference.
Well, Glenn, what you have mentioned about the preference for in-person interpreting is very much true. Visiting the doctor is stressful by itself. And then if we add the use of technology, the phone, the video, this may add the stress to the patient. And we know also that the nonverbal language is a part of the content of the communication. And if we are using a telephone, we're not seeing the nonverbal cues. So I think as much as possible, we try to do the in-person. But of course, technology and the need of professional interpreters makes us resort to the technology. Another thing that we have seen in this field of using technology is the use of interpreters that are overseas. If they are located overseas, well, they may not have received a good training about what the healthcare how the healthcare system is here in the United States. They don't know about localization. They don't know about the person who they are interpreting for. So they are not aware of what problem the patient has or the regionalisms that the person is going to use, like it is different. I'm from Peru, and when I interpret for people that are from Mexico, let's say, they use the word angina for amygdala. And that, if I receive a word like that in Peru, it's not going to be used. How would you know if we have person in Spain or Argentina? So it's, that is posing some difficult and will affect the accuracy of the interpretation. Then also saying that a pre-huddle before the meeting, I think it's very necessary. I think it's very beneficial for both professionals, for the doctor who will know how the interpreter is going to perform his or her services, if they will do a signal to stop or to slow down, if they will use if they will use the first person, because sometimes all of a sudden you begin interpreting in first person, and if you're not aware that we are doing that, it leads to confusion. On the other hand, the interpreter will benefit also because The interpreter will be aware of what the patient is going through, if there is something important that we need to know, and what to expect to begin searching the terminology, the tone, and anything else needed to do an effective interpretation, an effective communication. So this pre-huddle with the interpreter ensures that both parties are on the same page, and they are acting as a team, and they are ready to provide the best possible care to the patient.
I want to highlight what you said about the interpreter as being part of the medical team. I know that interpreters just serve such an important role in terms of providing quality care for our patients. I'd like to shift gears just a little bit, but talk a bit more about what arises and what issues may come up when we are using interpreters who are not qualified and not professionally trained, also referred to as ad hoc interpreters. For those who are unfamiliar with the term, an ad hoc interpreter is someone who is called to interpret but is not formally trained. So this may often be a family member or perhaps a bilingual staff member who has not received interpreter training. These situations are particularly challenging and not ideal for a number of reasons, which are shown in this testimonial clip that we'll provide for us today.
Growing up, I was often the one that had to help my parents with their interpretation needs, and I really wish that I wasn't that person to have to convey all of their healthcare concerns. I really do believe that I would have liked a third party involved, a third person involved, so that the initial shock, the initial harshness of the message wasn't transferred from me to them. Many of the Latinos in our community have shared experiences, and today I'm going to talk about one of the many times that I've had to interpret for a family member and how it was one of the worst days of my life. My mother and I, we were on a routine checkup for her with her nephrologist, and weeks prior to that, I was starting to notice a decline in her health. I started noticing new symptoms that she had before. And so going into this routine checkup, it was very alarming, and I was very apprehensive going into this, and I know that she felt the same way. Once we were there, we saw the doctor, and we saw that he was just looking down towards the floor. And after we sat down, he had told us that we needed to have a serious talk, a serious plan for what's to come. As soon as he said for what's to come, I knew that I wanted a third person involved. I knew that I wanted another interpreter in this situation, because I knew that this was going to be a very heavy topic to talk about. And I knew that this would not only affect me, but also affect my mother. I knew that we needed an interpreter, but I know that I wasn't able to ask for one because I've never seen an interpreter in that situation or in his clinic. And why I didn't see one, I don't know. I don't know why he never had any type of interpreters present. I don't know why I didn't ask for one. I guess I just really didn't want to be a hindrance to him or the clinic, I guess. Once we were running through the process of the interpretation and everything that he was talking about, I couldn't help my mind go like at 100 miles an hour. I started thinking about memories. I started thinking about my mom, that I was possibly going to lose her, all the times that we have spent together. And I couldn't help but feel a sadness within me. But I knew that in that moment, I still had to be a professional, and I couldn't express my emotions in the moment. The urge to cry was growing within me, but I knew again that I needed to maintain my professionalism in that situation. I knew that after looking at my mom and telling her everything that the doctor was saying, that she was hurting. And not only for her health concerns, but she knew that I was hurting as well. And in that situation, I couldn't help but think, what is to happen? What is to happen next? The situation for both of us was very emotionally draining, and I know that my mom would have preferred me to not have been the one to interpret this message for her. After we were done talking about her treatments and her kidney and everything that has to go within this process, we got very somber in our expressions. And it wasn't until that we left the clinic, walking to the car, that it dawned on us what just happened. 5 minutes into driving, my mother and I bursted out crying because we couldn't handle the situation in the moment. The heaviness of the situation dawned on us, and it was very, very hard.
What a difficult position for Ivan in this video. I cannot imagine his emotions and trying to be professional at the same time. It is very stressful for the bearer of bad news, but the need to share those bad news with your family member, with your loved ones, it's something else. I cannot imagine that. The emotions may lead to lack of objectivity, for example, trying to lighten the message and not saying exactly what the doctor is saying because the family member is deciding not to tell the patient the truth. And that happens in some cultures where the doctors don't tell directly the patient the truth. They call a family member. So if we're thinking of cultural issues, this may happen too if we're using a family member or a friend. Another things that can be affected with the use of a family member is that confidentiality. And in good faith, the interpreter or the family member can tell other members of the family or other friends trying to get some more help for the patient. So confidentiality is affected. For example, if it's a terminal illness, many people in Hispanic cultures, they will tend not to tell the patient that they do have a terminal illness. They will just cover it up with something and will keep helping with the interpretation or supporting, because they think of this as they are supporting their family member, they are helping them. And it is in good faith, but the interpretation is not being professional and objective. So I think that this may cause misunderstanding, also in the relationships, because if the patient knows, there can be a distance. They can affect the treatment as well, because it will depend on what the family member decides instead of the patient. So you go and you trespass the role of the interpreter as a family member. And the confidentiality, as I say, may be exposed, the private information, and the professional interpreter wouldn't do that. This might be thought as a gesture of support, but it is not. And not only that, but let's think about the level of knowledge of the terminology. Glenn mentioned the difference between being bilingual and being an interpreter, a trained interpreter. Training is needed for terminology, but also for the use of best practices and techniques when interpreting. When it comes to a second generation or third generation of the speakers of another language, they have had their education here in the United States. So their language, the English, is good, it's excellent. But let's think about that second language that they learn at home. What's the level of their terminology, grammar, everything in that second language? Is the colloquial language that they spoke at home? Is it, have they traveled a lot to their country to get all the, vocabulary? Have they limited to colloquial language? Have they done any education in the other language? So many things to consider, and it is very difficult to evaluate their proficiency in the other language. And if we, more than that, not only use a family member as an interpreter, but if we use children, then we have to consider more than that, because they may struggle with the vocabulary. A child, even in English, won't be aware of terminology that is used in the medical field. And of course, we have an example of a child that was used as an interpreter and was trying to interpreting in Spanish, su muñeca está rota. which is mean your wrist is broken, but the word muñeca for a little child means doll. Then the interpretation was your doll is broken. So it's kind of funny, but this is what we have. And then not only that, but also the stress, the responsibility that you place into a child, and that may affect him or her. So I think it's very, very important to think of all these facts that go with the use of a family member, with the use of friend, with the use of a minor, and it is very inappropriate to use a minor especially, unless, of course, there is an emergency and you don't have any other resort, so that will be the last resort.
Yeah. Those are all great points, Rommy. I think, again, it just reaffirms the importance of why, whenever possible, we should be using qualified professional interpreters. Along those lines, these professional interpreters are trained to focus on working toward providing transparency as well as promoting accuracy throughout the encounter. As part of this, everything that is said in the room should be interpreted for transparency.
Yeah, so I just want to talk a little bit about transparency. And remember, I mentioned the code of ethics that kind of shapes the interpreting profession. Well, one of the ethical principles and ethical categories that interpreters hold to is the notion of transparency, meaning that we should be, no one should be thinking when an interpreter is present that they're not in the know of what's going on, right? Because the interpreter really is there. The function of the interpreter is to build that trust and that rapport in the clinic, in the clinician-patient relationship. The interpreter is an aid to creating that rapport. So, transparency is very important because it allows that rapport, that relationship to build, right? So, when we talk about transparency, we really need to avoid things like side commentaries, discussions. These can be perceived as ways that are creating distance between the clinician and the patient rather than bringing them together. Use of idioms as well can also be a challenge for transparency.
That's correct. I mean, like clinicians need to develop that rapport with the patient, and different cultures have different ways to do it in their own countries. So I mean, like the way you greet the patient, and many other things. And when you said, Glenn, about this creating this rapport, humor takes place. But the problem with humor is that it is based in context. It is based in something you already know, that something that is located in your own culture and in your own, maybe your locality, the TV show, or something that you already know. And that can be really challenging to interpret. Humor doesn't translate very, very well. It may contain wordplay, cultural references, and then the translation is lost. The translation gets lost. And also distracts the attention of the patient and the attention of the interpreter, trying to look for something that, would say the same in the other language. For example, in my community, when I do interpretation and there is a joke that is impossible to translate or to interpret, I just say, please, out of courtesy, laugh, because they are making a joke. And they are making a joke about this topic or the other topic. And that's all I mention, because it's almost impossible to use and it usually works.
I can imagine where those situations would feel a little bit awkward. These are all good things for us to remember as we are caring for our patients and in these clinical encounters.
Yeah.
A few additional points to keep in mind when communicating through a medical interpreter is that we should also ensure that we address the patient directly and speak in the first person. Aim to speak in short sentences and pause regularly to allow for interpretation. And ideally, in most circumstances, seat the interpreter next to or slightly behind the patient.
And I'd just like to add, when we talk about these ethical principles, well, transparency is one. Another very important ethical principle for interpreters is accuracy. It's very hard to be 100% accurate in a verbal interpreted encounter. We're trying to be accurate and follow our scripts here, and we're not very accurate, right? So, but the interpreter has the job of trying to promote, striving towards accuracy. And the principles that Colleen just mentioned, addressing the patient directly, speaking in the first person, speaking in short sentences and pausing regularly, seating the interpreter next to or slightly behind the patient. These are all resources that the interpreter has to promote accuracy. So as a clinician, you'll want to sort of collaborate with the interpreter in order to help the interpreter get as close to that goal as possible of being as accurate as making sure that the interpretation is as accurate as it can be.
Yeah, that's correct. Regarding the seating arrangement that you mentioned, Glenn, yes, the ideal position will be to the side and slightly behind the patient. And that is the visual communication is there, and it goes from the clinician to the patient and back and forth instead of looking to the interpreter. The communication, they have the autonomy of communication. But this is in the ideal world. We have to accommodate also to the rooms. Our rooms, sometimes they are very small, and then we need to consider the best practice that we can use. So we need to evaluate the space where we are, and the type of evaluation the patient is having, the type of work the doctor is doing, and what we need to accommodate the interpreter as an interpreter is being in the least obstructive position. And a position that also gives the patient privacy when it is needed. And even, like if you are in a mental health situation, they recommend us to be next to the doctor because we don't know what's going to happen there. So a little bit more of control of the situation, but everything, it's regarding what the room allows and the practice that is taking place. Another consideration is to be respectful and mindful of the cultural practices and preferences of the patient, like status, hierarchy, and other considerations. For example, a female patient may need a female doctor, or may need a female interpreter, or may need the permission of the husband to be seen by the doctor. And we need to be aware of what's going on there so we can be respectful and mindful of all of this. Nowadays, we also have to consider technology, and technology is making everything easier, but also everything more difficult. When the interpretation is not in person, where is the video going to be located? Where is the telephone going to be located? We are losing the non-verbal gestures. So it is essential to consider the technical requirements alongside the setting of the room and the visibility of the participants so they can fully engage in a direct and transparent and accurate communication.
I think you said that very well, Rommy. So the goal, again, of all of these steps and following them is really to ensure good communication in our clinical settings, and thus quality care and better health outcomes. A couple of final thoughts that are just part of any good clinical practice to close us out. One is documentation. So specifically in this area, it's always important for us to document when a formal professional interpreter is used. Along similar lines, if an interpreter is, for example, offered but a patient declines and prefers to use another option, that is their choice. That they have autonomy in that decision, but it is still important for us to document that this conversation has happened and that professional services were offered. Also, before we conclude an encounter, it's important that we confirm patient understanding. Again, this is true regardless of their preferred language. But one of the examples that is used often in terms of how to do this is to use the teach-back technique.
That's correct. That teach-back technique, as you said, Colleen, is very valuable as a tool to assess the understanding of the patient. The clinician may ask the patient to do that teach-back to tell the doctor again all the instructions about the treatment in their own words, in the colloquial words, in a way that they can understand. But this will empower the patient, of course, and makes the patient take an active role in their treatment, in their own health. But if the doctor doesn't do it or doesn't know how to do it, then the interpreter may share the level of understanding of the patient to the doctor. So the doctor or can suggest to do the teach back, or maybe in the pre-huddle they can discuss that. And because it seems like this has had a lot of good results, and I think that asking the patient to rephrase what he or she has heard in simpler words, it's a great method. Finally, I think that we can say that the interpreter and the clinicians, they are trying to facilitate an effective communication, bringing clarity to the misunderstanding, creating awareness of cultural issues, advocating for the patient when it's needed. And in this way, the interpreter is helping to promote better health outcomes, which is the main goal, the main goal of the team formed by the patient, the clinician, and the interpreter.
We mentioned earlier that having these important conversations, such as understanding how to care for people with diverse language preferences and learning about implicit bias, are needed for making strides to achieve health equity. Unfortunately, we live in a biased society, and higher levels of education and intellect do not make us immune to that bias. Yeah. As clinicians specifically, we need to consider the impact on patient comfort, on quality of care, on health outcomes, and to work towards overcoming our own biases. Mm-hmm. So how does working with an interpreter interface with things like how language ties to identities, to health equity, and using language as a marker for something else?
Yeah, so this is really a great point, Colleen. And, biased care is really the notion that the implicit biases that clinicians and patients bring with them to the clinical encounter have significant downstream effects and ultimately affect health outcomes. Implicit biases, and I can give a definition here, are attitudes and beliefs about race, ethnicity, age, ability, gender, or other characteristics, including ideas about language, that operate outside of our conscious awareness. They influence our judgment and can, without intent, contribute to discriminatory behaviors. So implicit bias in healthcare leads to things like microaggressions and other causes of harms to minoritized or historically marginalized patients. Philosophers talk about epistemic or testimonial justice, referring to the extent to which a patient is seen to be a knower, to be believed. And, classic examples of this exist in healthcare where, a clinician questions whether a patient is really in pain or whether the patient is really just trying to get access to prescription medications, right? And these are all tied to these sort of implicit biases and testimonial justice.
Mm-hmm. Yes. And these can be challenging situations, right? We know this because as clinicians, we are very committed to doing what is best for our patients and for their health. Mm-hmm. Implicit bias, by definition, is unintended, but we do know that it happens and it affects our patients. It affects their health outcomes. In 2002, the landmark Institute of Medicine report, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, concluded that Although myriad sources contribute to these disparities, some evidence suggests that bias, prejudice, and stereotyping on the part of healthcare providers contribute to differences in care. So again, this was hopefully not new information to us now, but at that time, landmark. This was a very big notion, and hard for some of us to wrap our minds around. Examples of this, though unintentional when this occurs, but examples in the clinical settings include people who identify as Black or African American being less likely to be offered pain medications in the same scenarios when compared to white individuals. Women and people of color are less likely to be offered cardiac procedures than white males. And people with obesity may have symptoms more often attributed to their weight as compared to similar scenarios where someone is presenting with the same symptoms. In the context of communicating with the patient through a medical interpreter, as is our focus today, our unconscious biases, even before we walk into the room, may lead to things like feeling a sense of frustration or that we're already running short on time. This feeling as we're walking into the room may cause us to end up raising our voice, for example, as we speak to the patient, and subsequently affect how the patient feels after that encounter, and perhaps even affect their willingness to follow through with recommendations, the things we talked about, and their ultimate treatment plan.
Exactly. Yeah, and I think, Colleen, you have to recognize that whenever we have an interpreted encounter, we're actually moving from a dialogic relation to a triadic relation, right? Which means that the opportunities for implicit bias to show up are really multiplied, right? They're exponential because you have now another person inside the encounter, inside the interaction. So the presence of an interpreter complicates these kinds of biases and may actually heighten discriminatory behaviors in numerous ways, even when someone is well-intentioned. So I just want to give a couple of examples of how there can be implicit biases projected sort of onto the interpreter. So let's take the example of, you have the clinician asks the patient a question and the patient responds. The patient takes maybe 2.5 to 3 minutes to give this response, and the interpreter interprets the response in 2 sentences back to the doctor, right, or the clinician. And the clinician says, well, wait a minute. The patient spoke for 2.5 minutes and you just told me 2 things.
And this happens.
Yeah,
right?
It happens all the time. And, the clinician, I think, feels that the interpreter is not being accurate. The clinician feels that maybe they're saying more than what the clinician is being communicated. And, oftentimes I think we need to recognize that when an interpreter is doing their work, they are, by definition, striving towards transparency and accuracy, but at the same time, they're dealing with complex language. And what an interpreter is trained to do is not to mimic or transfer word for word what the patient is saying, but rather to mediate message by message, right? So there may very well be a case in which, in a particular language and particular culture, it takes 2.5 minutes to say something that in English you can say in 3 words, right? That can happen, right? So, I think that the clinicians need to kind of be aware of that sort of nature of interpreting in terms of message for message translation and not necessarily word for word. Another example is, a case where a patient and an interpreter laugh together, but the clinician sees nothing amusing going on. So, the clinician can feel left out of that interaction. And, we Rommy talked about humor not translating well, and that's often the case. But those can be areas where sort of the clinician's biases are feeding into to these negative reactions. And then finally, when a patient raises their voice, right, and the interpreter is going to mimic that same tone and register and style, the clinician might feel like she's being ganged up on, right? Well, I think that we need to think about the concept of the interpreter mimicking the tone, right? The interpreter is trying to get the message from one person in one language to another person in a different language. And part of that message is the tone, the style, right? The register, those kinds of language features that aren't necessarily words or sentences, right? But are somehow superimposed on language. So interpreters will try to convey that using those resources as well.
So those are all great examples of how biases may come into play through the interaction with the interpreter specifically. Again, leading to potential misunderstandings, poor communication, and ultimately downstream poor health outcomes. Are there times that unintentional and implicit biases may be projected onto the patients as well in the encounter?
Of course, I think we all have certain ideas or ideologies about language that we've sort of been socialized into since becoming speakers of a language, right? These include ideas like the way you speak marks how intelligent you are, how hardworking you are, how attentive you are. The idea that if someone doesn't understand you, you can speak a little slower, speak a little louder, right? And those are sort of ideologies and ideas. The idea that speaking or not speaking a language demonstrates your allegiance to a particular country or to a particular community. So all of these ideologies can be projected onto patients and result in unintentional discriminatory behaviors. For example, when a clinician makes the assumption that the patient will not understand a word or concept because they don't speak English, right? When a clinician walks into the room and begins speaking loudly, even though there's an interpreter present. When a clinician remarks that learning English is a mark of commitment to the United States. All of these are biases that are projected onto the patient, even in the presence of an interpreter, and the patients will typically sense them as well.
So these examples show that even the well-intentioned clinician, even though the well-intentioned clinician is treating the patient with their best clinical judgment and using the professional interpreter, there are still opportunities where for our implicit biases to serve as a barrier in that quality, high-quality care.
Exactly.
Another component of this to consider is the actual words that we use when we reference different groups of people. In research literature and legal language around language equity in healthcare, we often see the term limited English proficiency, or LEP, though some may favor alternate terminology such as linguistically diverse. What are your thoughts on this?
Limited English proficiency is a deficiency orientation. By its nature, it's limited, right? So it's a deficiency orientation. And many of the ideologies I described earlier are really inscribed in this sort of notion of this overarching notion of deficiency. I prefer to use the term language preference as opposed to LEP. Language preference, I think, gives agency to the patient to choose what their exact preference is. The fact that I prefer to use Spanish in some instances does not necessarily mean that my English is limited, right? If our goal is to treat the patient and not treat the language, then we should be open and accepting of the language that the patient prefers. Quality care and productive therapeutic relationships require that we engage with each other in ways that respect our preferences.
This reminds me of Tervalon and Garcia Murray's concept of cultural humility, so that idea of humility, that we should be accepting of various cultures, that we should not presume that we know everything about different cultures, and that we should always be open to learning as a fundamental disposition, in essence, to have a growth mindset. So can we talk a bit more about something like the idea of linguistic humility in healthcare?
Indeed. Yael Peled refers to linguistic epistemic humility. That's kind of her term, linguistic epistemic humility, as a central competency for clinicians. And she defines this notion of linguistic epistemic humility as an attitude of awareness on the part of those involved in the healthcare process of their own linguistic epistemic capacities in both intralinguistic and interlinguistic contexts, the recognition of their limitations, and the active search for sources outside of one's own linguistic epistemic capacities to overcome them. And what she means by this is the role of humility in multilingual healthcare situations is one that really invites us to be aware of language differences, to recognize our own limitations, and not to try to blame others for our own shortcomings. We often do that. We often try to blame someone else, and it's really our own shortcoming. The limitation, the limited proficiency is really ours as clinicians, right? We're the ones who are limited because we're not open to these language differences, and to actively search out resources to achieve common ground. So interpreters are indeed those resources, but this internal disposition to question ourselves and to accept the other as they are is a key competency, I think, in effectively serving patients with a language preference that is not English, and that always has to accompany the use of an interpreter or a remote interpreting service or any other language access mechanism.
Mm-hmm. This concept of linguistic humility isn't one that I have heard of as often, but I can certainly see how it ties in and connects with the care of our patients in the clinical settings. For me, this all comes back around again to living with a growth mindset and understanding that we all have more to learn. Mm-hmm. And a good place to start with this is our internal reflection and exploration of our own biases. One example of this that is referenced often in these conversations is use of the Harvard Implicit Association Test, or the IATs. And these are freely available online for anyone to explore and address topics broader than just race, but also in terms of like implicit biases around weight, for example. I think as we're wrapping up today, just reflecting on what makes this so hard, right? Mm-hmm. So for me, one of the greatest challenges that we face in these areas is that the work in and of itself is inherently difficult. It's not easy. It takes time and effort, but also intentionality, humility, and often a willingness to just be uncomfortable. Mm-hmm. And sitting in that discomfort is where we ultimately grow, but we have to be willing to put ourselves there, which doesn't feel great, right? It's not uncommon that addressing issues such as bias may carry strong emotional ties. I know we alluded to that earlier, that some people might have this gut reaction when we say, we're going to talk about implicit bias. And these kind of emotions, strong emotions, might be beneficial in some instances, but also can cause us to feel less open to discussion and less willing to be vulnerable. This is just something for us all to keep in mind as we continue to work towards making positive change with strives to improve health equity and particularly geared towards our historically marginalized populations throughout our communities.